which is, we were treating acute myeloid leukemia with 7 and 3 in 1977. We are still doing the same. What is the best way forward to change this by 2029?
Well, I'm recalling the date as a young physician treating in Reno, Nevada, patient in the county clinic, which was for free and was staffed with internal medicine residents. And we were in the midst of AIDS epidemics. I think that in today's dollars, the investment to fight eventually and to produce the first cures or at least meaningful therapies for HIV, so antiviral therapies, the investment was significant. And I wonder whether if we would translate it into today's dollar, whether this investment matches that we make to cure leukemia. So from the simple financial point of view, in terms of the strategy, I think we are doing what it's supposed to do, subdivide, see whether we can peel off certain sub-entities that we are better in treating. Acute promyelocytic leukemia comes to mind, new targeted therapies for the odd sub-entities of leukemia that can be better approached. And eventually we will have a sort of mix or a cure for all leukemia. Now the question is whether this will come from targeted therapy or whether we will be able to conceptualize and develop a lesion agnostic agent that addresses the common pathway or the convergent essential mechanism in leukemia, which would be preferential, but it might not be feasible.
Okay, second question. There are 3.5 million papers on cancer, 150,000 last year alone. But there's a staggering disconnect between great scientific insights and their translation into improved therapies. What are we doing wrong?
I think we are doing everything we can. The question is not whether 3.5 million papers is so many and yet we cannot cure anything. The question was whether in order to cure we needed 6 million papers. So the fact that there are a lot of papers but not sufficient to cure just begs for the question that maybe there should be more research and of course more research report. So what is a threshold at which meaningful cures will be produced is a question, and obviously if we measure this threshold in number of publications, 3.5 million is below this threshold. So how do we produce more papers? More research is needed. The question, of course, is related to the merit system in academic medicine, whereas the metrics are publication, and sort of not everything that can be published should be published. This would be a sort of sarcastic point of view to it. But I think simply that the 3.5 million papers is just not enough to produce a cure. So we need to produce more papers. So it's a sort of opposite answer as to, I think, expected, but I thought a lot about it.
Question number 3. The fact that children respond to the same treatment better than adults seems to suggest that the cancer biology is different. But then, of course, the host is different also. Since most cancers increase with age, this means that even having a good therapy may not matter because the host is decrepit. Your solution?
I would see this question and this problem from different angle. Aging is the single most powerful predictor or risk factor for cancer. If we were able to retard aging and suppress it, let the age, theoretically, just for discussion saying, at the age of 60, we would probably eliminate 80% of cancer. So I think that the prevention of cancer should, of course, focus on the obvious things, not smoking, living healthy, etc. But these are a sort of no-brainers that do not require a much of buy-in or convincing. It's like a climate change, right? I mean, you don't need yet another study to know that there is global warming. I think what needs to be done is a major investment in aging or age retardation research. If you think about it, how many drugs do we have that are known to decrease the rate of aging? You know, very few. And this is where I think the key would be.
You have great knowledge and experience in the field. So if you were given limitless resources to find a cure for cancer, what will you do?
I think that one would identify the key points in the pathogenesis of cancer, in our case leukemia, and develop working groups around these key points along the pathophysiologic cascade, and would also allow for long-term projects whereby the science is not driven by consistent and ongoing battle for funding, which creates a tremendous disruption in the process of discovery. So much energy is spent on getting funded rather than getting a meaningful result. So clearly, issue of money would be paradigm shifting if we could, at least in a certain area or in a certain place, decouple the issue of constant struggle for funding from discovery process.
And how do you plan to do that?
Well, I mean, this is a hypothetical scenario, whereas there is a funding source that would be transformational. I firmly believe that, and again, I want to get back to the AIDS epidemic, that the initial investment, national investment in producing the first nucleoside analogs, reverse transcriptase inhibitor, which required maybe in today's dollar, I don't know how many millions or billions of dollars, if we would devote this type of money to cure of cancer, this is clearly would have tremendous impact and produce results. There is no question in my mind that this is an issue of financial priorities. And by the same token, if we look at the national debt of United States measured in trillions, but really nobody really knows. And I just give you only one suggestion. If I were to suggest that today's the national debt is 1,588 billion versus 1,590 billion, we are talking 4 billion difference. Would you second guess me on it? Would you call your representative in Congress? Would the market break? Would there be any yet this 4 proverbial billion? And I don't know whether this would be amount of money that we need would be so consequential to cure of cancer. So the amount of expenditure for things that we don't know even what they are, and once we start speaking trillions and billions, and we see it in a prospect of a national debt and national priorities, it becomes obvious that we don't have the heart on the right side, on the proper side of our body. This is not where we have. The idea is that we all are going to be affected and that we are all going to age, yet we spend a fraction of it, of the wealth that we have, on something that we are all become or will become a victim one way or the other. It's just mind-boggling.
Excellent. Last question. And I'm particularly moved by the fact that you take care of patients all the time, and so you are dealing with this question I'm going to ask you. Offering patients with advanced stage, non-curable cancer, palliative but toxic treatment is a service or a disservice in the current therapeutic landscape?
There are two things to it, as I see it as a practicing physician. One, I want to quote a study, to be controversial, of a perception gap as to how the doctor thought when the treatment discontinuation was discussed with elderly patient with myelodysplastic syndrome, of the toxicity, inconvenience treatment, and how patients think about it. And the results were stunning. Most of the doctors had exaggerated the impressions they have as to how the patient is inconvenienced by treatment. I mean, this was a stunning result, and I can quote the study. In our words, we have to individualize it. For many patients, having a hope is more important than a momental side effect. For many patients, the hopelessness of the situation is by far more tragic than a given side effect. So this is one side of the story. Application of futile therapies is, of course, borders on malpractice, so it has to be seen in very serious context. Yet the benefit of the therapy or being under treatment might be tremendous to the well-being of the individual, depending on the psychological constitution of the patient, of a given patient. So it's very important. I see it right away among my colleagues that on service or in terms of decision for palliative care, there are those who are much more likely to obtain consent for palliative care from patients than other doctors, which I can't help thinking that those who do it are not necessarily always on the right side, because so there is some error, I think, in both directions. The typical scenario is that you come to a patient and you say, well, but you will have this terrible drug that will make you vomit and stuff and so on. Or we are going to do the chest compression, do you want to be intubated, etc. Why don't we write the non-resuscitation order? And if we do the non-resuscitation order, what is the alternative? You are dead. I mean, so it has to be, I think there are errors made, not intentionally, and of course with good intent on both sides, whereas therapies are discontinued prematurely or they are continued futilely. But it's a very personal decision, and most of all, the patient has to be ready mentally.
Thank you very much, Jaroslaw. Very excellent, thoughtful.